Think about the one specialist you refer your absolute worst, most complex cases to. I want you to picture them right now.
Yes, that is a brilliant mental exercise to start with.
Right. Because I don't mean a generalist you use to just, cleared your backlog.
Mhm.
And definitely not just the next available name on the hospital's rotating on-call roster.
No, absolutely not. You're talking about that specific person.
Exactly. I mean, that very specific clinician who immediately springs to mind the absolute second a really particular, highly complex problem walks through your clinic door. Notice the physical relief you feel when you look at the patient's chart and realize, this is a case for them.
You think, I don't have to struggle through this alone?
Yes. Consider who that is for a moment. I mean, why them? Was it the surgeon you immediately rang for a complex revision case where the primary procedure had failed catastrophically?
Leaving a massive bone defect,
Yeah.
usually?
Right. Or is it the rheumatologist who willingly takes on those incredibly tangled, overlapping autoimmune presentations?
Mm-hmm.
The patients with systemic lupus and secondary vasculitis who leave everyone else in the multidisciplinary team feeling completely out of their depth.
Or perhaps it is the internist who truly understands the intricate metabolic cascades of long-term hormone replacement therapy, rather than just ticking boxes on a standard protocol.
Exactly. And let's be brutally honest about how that clinician became your absolute go-to. I mean, they didn't earn that status in your mind via a flashy marketing campaign.
No, there were no billboards involved.
You didn't receive a glossy, high-production brochure in the post that magically convinced you to hand over your most medically vulnerable patients.
It doesn't work like that. They became the obvious choice through the slow, relentless accumulation of doing something highly specific exceptionally well and repeatedly.
Right, until your own brain simply categorized them. That mental filing cabinet where you place them, that is their clinical niche.
That is the precise reality of it. And it is vital to establish right at the beginning of this deep dive that in the medical profession, we have a terrible, pervasive habit of leaving our own reputations up to chance.
Oh, absolutely, we do.
We undergo 10, maybe 15 years of rigorous, structured training. We are tested on everything from cellular pathology to complex surgical approaches.
Right.
Yet when we finally reach the consultant or attending level, we treat our professional trajectory as an exercise in passive accumulation.
We just sort of sit back and keep our heads down.
Exactly. We clear our clinic lists and hope that somehow the wider community will organically figure out what we are actually best at. And today is about completely dismantling that passive approach.
That sets up our mission perfectly. Because today, we are dissecting the architecture of building a clinical niche on purpose.
On purpose being the operative phrase there.
Yes. This is not a conversation about merely surviving in a medical career, nor is it, a superficial guide to medical marketing. We are laying out a highly practical, strategic blueprint aimed at mid to senior professionals who want to become the clinician that others actively seek out.
And crucially, how to do that without turning into a narrow one-trick practitioner whose broader clinical skills just atrophy into nothing.
Which is the big fear, isn't it?
It fundamentally comes down to career sustainability. Niche building is not about branding. It is the precise mechanical process by which a clinician turns their raw, unshaped clinical skill into a highly focused reputation.
A reputation that actually works for them.
Precisely. That reputation is then converted into targeted, high-trust referrals. And those targeted referrals ultimately build a practice filled with the exact patients you actually want to treat.
Rather than just taking whatever comes through the door.
Exactly. The alternative is a practice dictated entirely by the random whims of the hospital triage system, the general referral pool, and, well, the sheer luck of the draw.
And no one wants to build a 20-year career on luck. So we need to draw a stark, defining line right away between two concepts that I hear constantly conflated in hospital corridors: a subspecialty and a niche.
Yes, this is a massive distinction.
Right, because looking at the practice management data, a subspecialty is essentially a credential. It's a fellowship you completed. It's a board exam you passed.
It is the piece of paper hanging in a frame behind your desk.
Exactly. It gives you technical, legal, and institutional permission to practice in a specific domain. But a niche is entirely different. A niche is a reputation. It's entirely about how other people perceive your value in real time.
That divide permission versus perception is where an enormous number of highly intelligent, incredibly capable mid-career professionals make a devastating error in judgment.
How so?
Well, we are conditioned by the entirety of our medical training to believe that the credential is the finish line. We assume, quite logically, based on our training environment, that because we have completed a highly competitive, prestigious fellowship in, say, complex upper limb reconstruction.
Right, you think everyone will just know.
Exactly. You assume the wider medical community will automatically, deferentially recognize us as the ultimate authority on complex shoulder arthroplasty.
But they don't.
No. Having a fellowship simply means you possess the paper. It is a baseline. It is table stakes, really.
Yeah.
There are countless fellowship-trained surgeons out there sitting in empty private consulting rooms or grinding through completely generalized, untargeted public hospital referrals.
Simply because they have never taken the time to cultivate a specific perception in the minds of their referring colleagues.
Exactly.
But wait, I have to stop you there. Because we live in an era of intense clinical governance, hospital boards, and massive medico-legal scrutiny. If the paper doesn't actually matter in terms of filling the clinic, why are hospital boards mandating it?
That is a very fair point.
I mean, are we just telling young consultants to ignore fellowships entirely?
Yeah.
If the institution relies so heavily on credentialing, isn't there a risk that we are undervaluing the subspecialty?
That is a critical distinction to make, and it really comes down to understanding who the credential actually serves. Institutions, the hospital boards, the medical indemnity providers, the clinical governance committees, they naturally rely on credentials because credentials are easily quantifiable.
Right, they can just check a box.
Exactly. A hospital administrator can verify a fellowship certificate in a matter of seconds, but they cannot easily quantify a reputation in the community.
Oh, that makes sense.
The credential acts as an institutional safeguard. It's a baseline metric of legal and clinical competence that protects the hospital from liability. You absolutely need it to get operating privileges or admitting rights.
So it's not negotiable for employment.
Yes. However, the trap for the clinician is believing that the institution's metric of competence is the same thing as the community's metric of value. They are fundamentally different ecosystems. The hospital requires your subspecialty credential to grant you permission to work. But the general practitioner in the community, the sports physiotherapist, the emergency department physician, they do not send you patients because of your certificate.
They probably don't even know what your certificate says.
They rarely even know where you did your fellowship. They send your patients because they perceive you as the most reliable, frictionless solution to a specific clinical problem they are currently facing.
That makes the reality of referral networks much clearer. I mean, the institution cares about the baseline. The referral network cares about the apex. But let's ground this. Give me a concrete example of what a powerful niche looks like when it exists completely independent of that formal subspecialty credential.
Okay, consider the classic example of a general orthopedic surgeon working in a large, busy regional hospital.
Okay, painting the picture.
Over the course of perhaps 5 or 6 years, this surgeon begins taking a particular quiet interest in complex foot reconstructions, specifically diabetic Charcot neuroarthropathy and severe post-traumatic deformities.
Oh, those are tough cases.
Incredibly tough. For those outside of orthopedics, Charcot foot is an incredibly destructive, rapid bone collapse secondary to severe peripheral neuropathy.
Right.
It is a condition that terrifies most generalists because the complication rates are astronomical, the infections are relentless, and the amputations are frequent. It requires immense patience.
So most surgeons are actively running away from these referrals.
Exactly. But our general orthopedic surgeon begins aggressively reading the literature on this. They spend extra time in their clinic meticulously managing these patients. They liaise closely and constantly with the local endocrinologists, the tissue viability nurses, the orthotists.
Building a whole ecosystem around it.
Yes. And here's the key. Nobody ever handed this surgeon a formal certificate for this highly specific expertise. They did not complete a dedicated 12-month foot and ankle fellowship.
Wow.
Yet, if you look at their clinic list today, it is absolutely packed with these highly complex specific cases. The local endocrinologists bypass everyone else to send patients directly to them.
Because they've proven they can handle the complexity.
Precisely. They have built an ironclad, highly respected niche entirely based on perception and outcome, completely independent of a subspecialty credential.
So the credential opens the door, but the niche fills the chairs.
Yeah.
I love that. So if a niche isn't just a piece of paper, and it isn't something you can simply purchase from a medical society by paying your annual dues, it must be constructed.
It must be actively built, yes.
But here's the tension that every clinician faces, right? How do you construct a niche that is specific enough to be memorable, but not so narrow that your clinic sits completely empty? Because if you go too niche, you starve.
And that leads us to the fundamental geometry of clinical volume. It is a genuinely terrifying prospect for a private practitioner or a clinician trying to build an academic base to specialize too deeply.
You have overheads to pay.
Exactly. If your declared niche is a 1 in a million genetic bone dysplasia, you may rapidly become the world's leading expert. But the stark reality is that you will not have a busy local practice.
The math just doesn't work.
The math simply does not support your overheads. Conversely, if you remain a pure generalist, your potential patient pool is massive, but you are competing with every other competent practitioner in a 50-mile radius.
And you're competing solely on availability rather than expertise, which is exhausting.
It's a race to the bottom. So the solution to this volume versus specialization dilemma is a strategic concept known as the intersection niche.
Okay, let's really dig into this intersection strategy because I think this is where the actual mechanics of practice building start to make sense for people who are currently feeling stuck or overwhelmed.
The most valuable, lucrative, and sustainable niches in medicine are rarely the deepest ones. They are not about drilling downwards into one singular, increasingly microscopic, subcellular pathology until you are the only person on Earth who understands it.
Right, it's not a PhD thesis.
No, not at all. Rather, the most robust niches are intersectional. This involves combining two, or occasionally three, distinct areas of clinical practice that almost no one else thinks to integrate.
It's essentially creating a Venn diagram where you are the only practitioner sitting comfortably in the overlapping center.
That is the exact visual model. And the profound beauty of this approach is that you do not need to manufacture some incredibly exotic or bizarre clinical combination to make it work.
Thank goodness.
Right. The most robust, sustainable intersections emerge organically from what a clinician already does, what they genuinely enjoy reading about, and the specific patient mix that consistently lights them up and makes the long administrative hours worthwhile.
So the true work is not inventing an entirely new medical field.
No, the work is simply noticing the intersection that is already quietly forming in your day-to-day practice, naming it, and then deliberately reinforcing it.
I need to see the mechanics of this in action. Give us a detailed example of this intersection move playing out in a real clinical environment. How does this actually capture a referral market?
Let us examine the highly saturated field of sports medicine. In any major city, there is an absolute abundance of sports medicine physicians.
Oh, everywhere.
If you simply market yourself as a sports doctor, you're drowning in a sea of identical colleagues. Now, within that large group, there is a smaller, well-defined subset who have chosen to specialize in dancers, ballet, contemporary theatrical performance.
Okay, so that is a solid, recognizable subspecialty.
It is. But let us look for the intersection. What if we have a clinician who specializes in dancers but also possesses a deep, meaningful clinical background in managing adolescent eating disorders and the female athlete triad?
Oh, wow. That is incredibly specific.
Let us break down why that combination is so powerful. The female athlete triad involves the complex interplay of relative energy deficiency in sport, menstrual dysfunction, and decreased bone mineral density.
Right.
It is an incredibly difficult metabolic and psychological web to untangle. Now think about the demographic of elite young ballet dancers.
The pressure is immense.
The intersection of intense physical performance demands, chronic nutritional deficits, immense psychological pressure, and repetitive orthopedic injury is a massive chronic problem in that specific population.
Yeah, that makes total sense.
A standard sports physician might treat the stress fracture in the dancer's foot, but entirely miss or ignore the underlying anorexia that caused the bone density to plummet in the first place.
Because it's not their domain.
Exactly. And a standard psychiatrist might treat the eating disorder but have no idea when it is biomechanically safe for the patient to return on point.
So the clinician who sits in the center of that Venn diagram isn't just offering a service. They're solving a multidisciplinary nightmare for the patient, the parents, and the dance academy.
Precisely. That clinician has integrated orthopedics, sports psychology, and metabolic medicine. They are incredibly specific, highly sought after by a very targeted, motivated demographic.
But the problem they are solving is prevalent enough within that demographic to guarantee a steady stream of referrals.
Exactly. They are no longer competing with the general sports physician who treats 40-year-old weekend warriors with tennis elbow. They have created an entirely new category of one.
If you're a clinician listening right now, this must sound incredibly empowering. Because when we typically hear the word niche, the immediate internal panic is, I have to abandon 80% of what I know. I have to throw away all these diverse skills I just spent 2 decades acquiring.
Yes, that fear is very common.
But the intersection move completely flips that anxiety. It reframes niche building from abandoning what I know to layering my existing interests. It's an additive process.
It is entirely additive. It is about synthesis, not reduction. You are taking disparate strands of your training and weaving them into a rope that no one else possesses.
But practically speaking, how does one actually do that in the crushing grind of a modern hospital environment? I mean, you're seeing 40 patients a day, you have ward rounds, endless electronic health record administration, clinical governance meetings. You are operating on fumes.
It is a brutal environment.
Right. How does a clinician practically engage in this deep process of noticing and naming their intersection when they barely have time to eat lunch?
It cannot be a massive, time-consuming philosophical undertaking, or it simply will not happen. It begins with a very quiet, microscopic internal audit.
Okay, what does that look like?
For a period of about a month, at the end of every single clinic, I advise clinicians to sit at their desk, take 2 minutes, literally just 2 minutes before they go home, and ask themselves 3 questions.
2 minutes. We can all do that.
Exactly. Ask, which patient today was genuinely intellectually satisfying? Which case did I not mind running late for? And which specific pathology made me want to go and read a journal article, not out of a sense of grim obligation, but out of genuine clinical curiosity?
Ah, you're looking for the bright spots in the data.
Exactly. Over a month, irrefutable patterns begin to emerge from your own daily practice. You might notice that while you're technically a general upper limb surgeon who sees a lot of routine rotator cuffs, the cases that truly engage your brain and make you feel like a master of your craft are the complex trauma reconstructions in elderly patients with significant pre-existing osteoporosis.
That is your intersection right there.
Yes, upper limb trauma and geriatric bone fragility. Once you notice it, you must name it. You begin to internally identify as the surgeon for complex osteoporotic upper limb trauma.
Okay.
That internal naming, that psychological shift in how you view yourself, is the crucial non-negotiable first step.
Okay, so I've done the audit. I've figured out my intersection. I'm the osteoporotic upper limb expert in my own head. But keeping that named intersection a secret in my own brain doesn't pay the bills.
No, it certainly doesn't.
The triage nurse doesn't care about my internal identity. They care about who is on the roster. If my clinic is in a basement office and I don't have a massive marketing budget, how does the local geriatric clinic or the emergency department actually find out I exist in this capacity?
This brings us to the vital and, frankly, often misunderstood art of professional signaling.
Signaling.
Yes. Signaling is where many highly competent, scientifically minded professionals feel deeply uncomfortable. They automatically equate signaling with aggressive self-promotion.
And in the medical profession, overt, boastful self-promotion is rightfully viewed with deep suspicion.
Precisely. But building a niche requires clear, consistent professional signaling so that referring offices remember you when the time comes. The challenge is doing it effectively without overdoing it. There is a dangerous, very modern trap here.
Because,
The risk of becoming a caricature of yourself.
oh, let's explore that trap. Because anyone who spends 5 minutes on medical social media sees it constantly, the loud physician branding phenomenon.
It is ubiquitous now.
It is genuinely exhausting when you interact with a clinician who simply cannot have a normal peer-to-peer professional conversation without forcibly, awkwardly steering it back to their single solitary topic.
Yes, it feels incredibly artificial.
And frankly, it often repels serious referrals rather than attracting them. So what is the actual alternative? How do we signal gracefully?
We have to understand the mechanics of how medical professionals actually communicate trust. If we categorize the mechanisms of professional signaling, we see that it is not about shouting. It is about the accumulation of small, highly targeted directional choices.
Give me an example.
It starts with the very subtle. Think about the elevator pitch you use when a new colleague or a junior doctor asks what you do. Instead of saying, I do orthopedics, you say, I'm an orthopedic surgeon, but I spend most of my time focusing on osteoporotic trauma.
Ah, it's setting the frame immediately.
Yes, and it extends deeply into how you behave in multidisciplinary team meetings, the MDT.
MDTs are huge for this, aren't they?
How signaling works in an MDT is fascinating. You don't stand up and declare, I am the expert. Instead, when a routine case is discussed, you offer competent, brief agreement. But when a case that hits your specific intersection arises, you lean in.
You show your depth.
Exactly. You consistently offer highly nuanced, recent literature-backed insights on that specific subset of cases. Over a year of weekly meetings, every oncologist, radiologist, and pathologist in that room subconsciously learns that when a fragile bone trauma comes up, you are the definitive voice in the room.
That makes total sense. What about the physical correspondence? How does a GP sitting miles away get the signal?
The clinic letter is perhaps the most underutilized signaling tool in modern medicine.
Really?
Absolutely. The GP reads your discharge summary. If you use a generic, auto-populated hospital template that simply says, fracture fixed, follow up in 6 weeks, it signals nothing. It tells the GP you are a technician.
Let's forget it.
But if your letter includes a targeted, insightful paragraph outlining a specific osteoporosis management plan, referencing a recent guideline, and directly advising the GP on the subsequent bisphosphonate protocol,
You are sending a massive signal of expertise.
over time, this deliberate, consistent alignment in your letters, your NDT contributions, and the specific conferences you attend results in a cohesive body of work. It consistently points the medical community in one unified direction regarding your value.
I think about it like this. Your niche should be a center of gravity, not a costume.
A center of gravity, yes.
Right, because when someone wears a medical costume, the loud branding, it's artificial, it demands constant attention, and it often obscures the real, complex clinician underneath. People look at the costume and think, well, they only do that one highly specific procedure. I certainly wouldn't trust their broader medical judgment on anything else. They become a one-trick pony.
That is the danger of the costume.
But a center of gravity is invisible. It's just this undeniable, quiet force that naturally pulls relevant mass toward it.
That is an exceptionally accurate way to view it. The clinicians who master this balance are instantly remembered for one highly specific expertise, their center of gravity, yet they remain profoundly grounded, well-rounded, and intellectually flexible on any other topic.
They're still real doctors.
Yes. You trust their judgment broadly, precisely because you sense that their specific expertise is rooted in a foundation of deep general competence. They haven't sacrificed their medical soul to build a brand. You want to be the knee ligament expert who is still entirely capable of intelligently discussing a complex abdominal trauma case without somehow making it about knee ligament.
Precisely.
So signaling tells the world what you will do. It attracts the right cases to your center of gravity. But here is where the mechanics of this get really counterintuitive. The true engine of niche growth, the mechanism that actually solidifies that center of gravity, is dictated not by what you accept, but by what you actively refuse to do. This is undoubtedly the most difficult psychological and financial hurdle for any clinician to overcome. A central, counterintuitive truth of practice building is this: growing a niche requires saying no significantly more often than you say yes.
Okay, this sounds great in a textbook. But let's talk about the gritty reality here. Put yourself in the shoes of a mid-career professional who has just taken the leap into private practice, or a newly appointed consultant with a massive mortgage, trying to build a referral base from scratch.
It is terrifying.
Saying no to a referral feels utterly reckless. It feels like financial sabotage. When you have clinic overheads, secretarial staff to pay, and medical indemnity premiums looming, isn't turning away any viable patient a fast track to an empty waiting room in bankruptcy?
It is entirely rational to feel that profound fear. We're trained from medical school to help everyone who presents to us, and we are economically incentivized in private practice to be as busy as humanly possible. But we must look past the immediate financial panic and understand the analytical, long-term reality of how reputation actually functions. This brings us to a concept I call the principle of dilution.
The principle of dilution.
Yes. Your niche, your actual bankable reputation in the medical community, is grown strictly by what you are known for. It is emphatically not grown by the sheer volume of what you are simply willing to do.
Break down the exact mechanism of how taking everything ruins a reputation. What does the GP actually think when they see this happening?
Think of your clinical reputation as a highly concentrated chemical solution. Every single case you take that perfectly fits your target intersection niche is a drop of pure concentrate. It reinforces your reputation.
Okay.
When the general practitioner refers a complex shoulder reconstruction to you, and they receive a brilliant, highly specific surgical outcome and clinic letter back, they think, yes, they are unequivocally the apex expert in this. Your solution gets stronger.
Right.
However, Every single routine case you accept that falls completely outside of your niche is a drop of plain water. It dilutes the solution.
So if you claim to the world to be the premier expert in complex shoulder arthroplasty, but your clinic letters to the local GPs are full of routine carpal tunnel releases, simple ankle sprains, and generic knee scopes.
The referring community subconsciously inevitably registers that inconsistency. GPs are incredibly astute at pattern recognition.
May see it all.
They see those letters and they think, well, they say they are the premier shoulder expert, but they seem to be doing an awful lot of general, low-level work. Perhaps they are not as busy with the complex cases as I thought.
Perhaps they aren't the apex expert after all.
Exactly. If a clinician indiscriminately accepts everything indefinitely out of a fear of an empty waiting room, they place a hard ceiling on their own professional trajectory. They dilute their reputation to the point where they become nothing more than a generalist with a hobby.
A generalist with a hobby.
Wow. They will never command the complex, high-value, intellectually stimulating referrals because they have not fiercely protected their professional identity.
But practically speaking, in the real world, how do you actually execute that? No. You can't just send a one-line rejection letter to a GP who is desperately trying to find a home for their patient.
No, that damages the relationship permanently.
Right, so how do you protect the niche without burning your referral bridges?
It requires mastering the slow, graceful, and highly strategic art of the gentle route. You never, ever simply reject a patient and leave the referrer stranded. Instead, you strategically and gradually begin routing non-fitting cases to colleagues who are better suited for them. We can walk through the exact mechanics of a Tuesday morning scenario.
Yes, let's do that. Give me the script.
A referral comes in from a prominent local GP. Your secretary flags it. It's for a routine carpal tunnel release. Your declared niche is complex shoulder reconstruction. You look at the notes.
And you feel that internal financial panic. I could do this in 10 minutes. It's easy billing.
But you resist. Instead of accepting it, you dictate a very specific letter. Or ideally, you pick up the phone to the referring physician. You say, "Thank you so much for thinking of me for this referral. While I am certainly capable of performing this release, over the last year, my practice has become highly focused almost exclusively on complex shoulder reconstructions."
Setting the boundary.
Yes. You continue. Because of that, my wait times for routine hand procedures are longer than they should be. However, my colleague Mr. Smith is exceptional at hand surgery. He operates twice a week on these exact cases. I have already taken the liberty of forwarding this referral directly to his team to ensure your patient gets the fastest, most focused care possible.
That is a masterclass in professional communication.
Yeah.
It's an act of service to the patient who gets faster care. It's an act of massive goodwill to the colleague you just handed a patient to, which builds reciprocity.
Yes, they will remember that.
And crucially, it sends a blaring, unmistakable signal to the referring GP about exactly what you do want to see.
Exactly. This is not about being precious or arrogant or acting as though certain routine cases are somehow beneath your dignity. It is a highly intentional systemic skill built over years.
It protects your time.
It ensures that the clinician's cognitive bandwidth, their limited surgical time, and their finite clinic slots are strictly reserved for the cases that actually accelerate the formation of their specific niche.
Right, because think of it structurally. If your clinic schedule is clogged with routine cases that you merely tolerate doing, you physically, literally do not have the space to accept the complex intersection case when it finally arrives.
That is the tragedy of it. The GP calls with the perfect case, and your secretary has to tell them you are booked out for 2 months with ankle sprains. You have to actively create the vacuum for the right cases to fill.
If saying no and routing patients is a skill that has to be developed and calibrated over years, then the timeline of when you actually start executing this strategy is absolutely crucial. And this leads us to what you've identified as the dual traps of timing. Because you can get this spectacularly wrong on both ends of the career spectrum.
You certainly can, and the consequences in both directions are severe. There are two massive career-defining pitfalls when establishing a practice identity: niching too early and niching too late.
Let's start with the young attendings, the newly minted consultants who just got their names on the door. What does the mechanics of niching too early look like, and why is it so dangerous?
We see this phenomenon frequently with new attendings. They emerge from a decade or more of grueling, highly structured training. They are driven by an intense, understandable psychological desire to stand out immediately in a crowded market.
They want to be known as the definitive expert right out of the gate.
So they precipitously declare a highly specific niche before they have actually experienced enough autonomous, unsupervised clinical variety to know what they truly excel at, or what they actually enjoy doing day in and day out, when the ultimate responsibility rests solely on their shoulders.
They pick the costume based on what looks good on the mannequin before they actually know where their center of gravity is.
That is exactly it. They might pick a niche purely because it looked lucrative in a practice management seminar or because they identified a temporary gap in the local market, but they possess no deep, abiding passion for the underlying pathology.
Which is a recipe for disaster.
The result is incredibly destructive to their long-term well-being. Because the identity feels entirely imposed from the outside, their day-to-day clinical work doesn't match their forced brand. Within 3 years, they begin to actively dread their own clinics.
Oh, that's awful.
They become locked into a professional trajectory they didn't organically choose, and untangling that false identity, telling the community, actually, I don't want to do that anymore, is remarkably difficult.
So what is the systemic remedy for the new consultant who is terrified of just disappearing into the crowd if they don't brand themselves on day one?
The remedy requires immense professional patience. I advise new attendings to spend their first 2 to 3 years being deliberately, unapologetically broad.
Really, just do everything.
Take the general trauma calls. See a wide variety of elective patients from the general pool. Expose yourself to different pathologies and different patient demographics. Pay intense attention to your own internal reactions.
Figuring out what actually resonates.
Yes. Pay attention to what frustrates you, what bores you, and what genuinely fascinates you. Let the true niche emerge organically from your own clinical data over thousands of hours, rather than trying to artificially impose it from day one based on a marketing theory.
That makes perfect sense for the start of the journey. But let's shift to the opposite trap, which I think is going to resonate deeply with many listeners today, niching too late.
This is a scenario I encounter frequently, and it is fraught with a very specific, heavy kind of professional grief. Picture the mid-career physician. They are perhaps 15 or 20 years into their consultant post.
Okay, they're established.
They have remained a reliable, hardworking, accommodating generalist for their entire career. They have taken every referral, covered every gap, but now, in their late 40s or early 50s, they are feeling a quiet, creeping exhaustion.
The burnout is setting in.
They are profoundly tired of being all things to all people. They look around at peers who established a clear niche a decade ago, and they see those colleagues enjoying highly focused, streamlined, intellectually stimulating practices.
And the generalist feels like they missed the boat. They think, I've been a generalist for 15 years. My entire referral network knows me as the dependable generalist who will take anything. It is far too late to pivot now. I just have to grit my teeth and ride this out until retirement.
That sense of resignation is pervasive, and it is the leading cause of late career burnout. But the truth, and this is vital for anyone feeling that way to understand, is that it is absolutely never too late to restructure the architecture of your practice.
If you are feeling that quiet exhaustion right now, listen closely. It is not too late to change the mechanics of your daily life.
The recovery framework for the exhausted mid-career generalist relies on the exact same logic we have discussed, but it must be executed with much greater precision and ruthlessness.
Because the runway is shorter.
Exactly. They do not have the luxury of spending 3 years exploring their interests, but they do have a massive, undeniable advantage. 15 years of hard clinical data to look back on. They already know exactly what they enjoy and what they utterly despise.
So how do they actually execute the pivot without destroying the practice they've built?
They apply the framework immediately. Step 1, pick the intersection based on their vast accumulated experience. Step 2, begin signaling that intersection aggressively to their established network.
And because they already have those relationships, the signal travels faster.
Exactly. Because they already have relationships with these GPs, the signal is received much faster than it is for a junior doctor. And step 3, and this is the most critical, terrifying step for the mid-career pivot, start aggressively but gracefully saying no and routing the cases that drain their energy.
It must feel incredibly daunting to change the rules of engagement 15 years in.
It does, but the timeline is reassuring. Within just 3 or 4 years of applying this discipline consistently, a practice that has been stagnant and exhausting for 15 years can look and feel meaningfully, radically different.
3 or 4 years of disciplined routing to completely restructure the back half of your career to save the next 15 years from misery. That is an incredibly high return on investment.
It absolutely is.
And reflecting on that quiet exhaustion you mentioned, it points to a profound truth about modern medicine. A well-built niche is actually the ultimate structural antidote to professional burnout. Which brings us to our final area of focus, understanding the niche as a center of gravity for long-term coherence.
When we talk about the epidemic of burnout in medicine, we almost exclusively blame systemic administrative issues.
Electronic health records, crippling administrative burdens.
Lack of hospital resources, declining reimbursement rates, those are entirely valid systemic failures. But a massive, heavily under-discussed driver of daily burnout is clinical incoherence.
Clinical incoherence. Explain the mechanics of that.
It is the severe cognitive fatigue of context switching. Imagine the day of a pure generalist. At 8 a.m., they're seeing a terrified 6-year-old with a pediatric fracture, requiring a specific communication style with anxious parents.
Very different energy.
At 8:30 a.m., they switch to an 80-year-old with an osteoarthritic knee and 5 severe comorbidities, requiring a completely different risk profile analysis. At 9:00 a.m., they see a 22-year-old elite athlete demanding a return to play next week.
The mental whiplash.
The mental gears required to constantly shift between these entirely different pathologies, communication styles, and risk tolerances 30 times a day is cognitively devastating. A properly constructed niche is not a cage that restricts you, it is a center of gravity. It is the core that holds the rest of a clinician's practice in orbit around something deeply coherent.
That coherence must actively eliminate a massive amount of clinical anxiety simply because you aren't trying to be an expert in everything simultaneously.
It absolutely does. Think about the routing strategy we discussed earlier. When you lack a niche, routing a patient feels like a personal failure, a loss of revenue, a loss of status, a subtle admission that you couldn't handle it.
Right, an ego hit.
But when you know precisely what you are known for, you no longer feel a sense of loss when routing non-fitting cases to colleagues. You feel profound relief. You know you are actively protecting your core.
And it must radically simplify professional development as well. I think about the sheer, terrifying volume of medical literature published every single month, the overwhelming anxiety of trying to keep up with all of it, the new biologics, the new surgical approaches across every joint, the changing pharmacology. It's mathematically impossible.
It is entirely impossible. And for the pure generalist, that impossibility breeds a constant low-level gnawing guilt. I should be reading more about this new biologic for rheumatoid arthritis. I should be reviewing this new minimally invasive surgical approach for the spine.
You never do enough.
But when you have a defined intersectional niche, that anxiety simply vanishes. Your niche acts as a filter. It dictates exactly what you must read, what you must master. And brilliantly, it gives you absolute permission to safely, guiltlessly ignore the rest.
Well, that sounds like a dream.
You are no longer drowning in a fire hose of information. You are drinking from a highly specific, curated stream. Furthermore, the entire trajectory for your career advancement becomes blindingly clear. You know exactly which 3 conferences matter each year, which specific research collaborations to pursue, and which hospital committees are actually worth your time because you are moving in a defined, coherent direction.
This coherence protects against that specific, slow loss of meaning that often catches generalists in their middle decades. It's that feeling of, I'm working incredibly hard, I'm exhausted every day, but what am I actually building? What is my legacy in this hospital?
That is the absolute crux of the matter. I have spent years observing the trajectories of senior clinicians, and here is a striking universal observation. When you look at the clinicians who are still genuinely loving their daily work at year 20 or year 25, the ones who still have a spark in their eye when discussing a complex case, they almost universally possess this center.
They figured it out.
They are deeply known for something. They didn't start with it on day one. They didn't buy it out of a box or hire a PR firm to invent it. They cultivated it deliberately, step by step, by noticing their own internal intersections, signaling quietly and professionally to their peers, and fiercely protecting their cognitive bandwidth. And that center of gravity protects them from professional drift and late career despair.
Okay, let's synthesize everything we've unpacked today, because this has been a profound roadmap for anyone looking to take control of their clinical destiny. The core philosophy here is that building a clinical niche is not some superficial modern marketing exercise.
No, it is not.
It is not about logos or website design or chasing social media algorithms. It is the slow, deliberate, highly strategic shaping of a medical practice toward the exact work that fits your unique cognitive skills, serving the patients who specifically need your unique intersection of knowledge.
Exactly right.
Clinicians who understand and execute this blueprint end up with referral patterns that feel almost effortless, and they build careers that grow quietly more fascinating and substantially more sustainable over time.
It represents the fundamental shift from being a passive recipient of whatever the hospital throws at you to becoming an active architect of your own professional life. And to ensure this conversation is not merely an abstract philosophy, but a catalyst for actual change, I want to leave you with 3 concrete, immediate actions to take this week.
Yes, let's get highly practical. What is step one for the clinician driving home right now?
Action 1. Tonight, sit down in a quiet room and write down the 3 types of cases you genuinely enjoyed the most over the last 6 months. And to be absolutely clear, do not list the most lucrative cases or the ones your department head thinks you should enjoy.
Be honest with yourself.
List the cases that make the chaotic, exhausting days feel genuinely worth it. The cases where you feel a deep sense of clinical flow and mastery. Once you have those 3 down on paper, look for the intersection between them. That intersection is the seed of your future niche.
Brilliant. Action 2.
Action 2. Select exactly one signaling move to execute over the next 90 days. Do not try to rebrand your entire professional life overnight. Pick one small, directional thing.
Keep it simple.
It might be volunteering to give one short, highly targeted talk at a regional GP education evening on your specific intersection. It might be writing one concise, practical clinical article for your hospital's internal newsletter. Or it might simply be refining a 2-sentence explanation of what you do and actively using it the next time a colleague in the corridor asks how you are. Just one deliberate signal.
Excellent. And the final action to lock this in.
Action 3. Identify just one specific type of case you currently accept, a routine case that drains your energy, that falls entirely outside your desired intersection, that you could gracefully route to a colleague who is a better fit. Just one case this week.
Try the gentle routing script we discussed.
And I want you to simply sit back and experience the physiological feeling of making intentional space in your clinic schedule. Once you feel that relief, the immense value of saying no becomes absolutely undeniable.
Those are powerful, highly actionable steps. And as we close today's deep dive, I want to leave you with a final, slightly provocative thought to mull over as you head into your next busy clinic. Consider how holding on to the cases you merely tolerate out of fear of an empty waiting room, out of habit, or out of financial anxiety might be the exact mechanism blocking the door for the complex, fascinating cases you are actually meant to treat. What would your Tuesday morning clinic actually look like? And how would it feel to walk into the hospital if you finally let the tolerable cases go? If this conversation helps you rethink the architecture of your practice, please take a brief moment to rate and share the deep dive with a colleague who might be navigating their own practice growth right now.